Good afternoon. My name is Andrea Kovach, and I'd like to welcome you to today's webinar. In collaboration with the Illinois Maternal and Child Health Coalition and Illinois Public Interest Research Group, this webinar is the first in a series of Illinois Health Matters webinars to be hosted by the Sargent Shriver National Center on Poverty Law. Each webinar will focus on specific populations and will feature experts sharing their advice about advocacy to win the best possible Affordable Care Act implementation in Illinois. Today's webinar addresses the effect of the Affordable Care Act on low-income children and their families in Illinois, and how the implementation choices being made now by Illinois policymakers may affect this population's access to affordable, comprehensive health insurance. After a few housekeeping matters, we will first hear from John Bowman, President of the Shriver Center, who will provide a brief overview of the landscape for national health reform implementation in Illinois. Next, we will hear from Kathy Chan. Kathy is the Associate Director of the Illinois Maternal and Child Health Coalition. Kathy will present on the Affordable Care Act public insurance provisions and their effect on Illinois' children and families. Then we will hear from Brian Imus, State Director of Illinois PIRG. Brian will present on how Illinois' children and families will be helped by the Affordable Care Act's new health insurance exchange marketplace and its new consumer protections. Last, we will hear again from John Bowman. John will present on the Affordable Care Act provisions affecting Illinois' health care delivery landscape and what these changes mean for children and families. Then we will open up for questions. If you encounter technical difficulties, please contact Karen Harris at karenharris@povertylaw.org. We would like this webinar to be interactive, and the presenters welcome your questions. Please keep in mind that we will answer your questions at the end of the webinar. Please use the questions feature on your control panel to submit your questions. Presentations, speaker biographies, and other resources will be available after the webinar at the link you see on the screen. And now, here is John Bowman.
Good afternoon. So we wanted to first set the context and just touch base quickly about the current situation and in order to understand what directions will go in after reform is implemented. For children under current law, as of July 1 tomorrow, children and families with households incomes greater than 300% of the poverty level will no longer be eligible for all kids because of the amendment to the Medicaid Act that was enacted earlier this year. Children from those families, however, who are already enrolled in the All Kids program will have grandfather status and be allowed to stay enrolled for 1 year. Of the 1.6 million children currently enrolled in the All Kids program, the vast majority are also enrolled in a primary care case management system called Illinois Health Connect, which is based on a medical home model that promotes primary and preventive care and makes referrals to specialists. However, under the current system, there are serious problems that insured children have with access to subspecialty care, and some have problems with access to primary care. Particular problems are evident in access to dental care and behavioral health care. A recent report in the Memisovsky lawsuit that became public about a week ago documents some of these access problems. All kids eligibility only goes through age 18. After that, it's cold turkey. So if you work with children who turn 18, you know already that they'd lose their health insurance at that age, and they have to either get it from an employer, get it in the private market if they can, or just go without it. Private coverage for children is plagued with the same problems that plague private coverage for adults. There's denials of coverage and price discrimination based on pre-existing conditions. And currently, there are about 148,000 children without health insurance in Illinois, 4.5% of the total population. Over half of Illinois' children, 53.4%, have private coverage, mostly employer-based. Government-sponsored coverage provides insurance for about 42% of all kids. For families, that is, for the adults and parents in these families, the number of the uninsured in Illinois totally is over 1.7 million. Currently, the family care program offers health care coverage to about 600,000 working parents and was expanded in January 2006 and still provides coverage up to 185% of the federal poverty level. For immigrants, there's no coverage for legal residents for the first 5 years and no coverage at all, ever, for undocumented unless pregnant women are covered under their moms and babies program. About 50% of Illinois births and over 90% of all births to teens in Illinois are covered by moms and babies, that is Medicaid. Most of this is fee-for-service delivery model. So you go to the provider and they bill the Medicaid program and get paid each time. There's mandatory case management at the primary care level for most people and a voluntary disease management program for people with chronic conditions. For adults as well as for children, there are big access problems getting in to see a doctor. Again, there's no coverage over age 18. This population, non-disabled adults and children, are about 76% of the whole publicly insured caseload, but only 43% of the spending. It's fairly, on the whole, a fairly healthy population. For private coverage, the employer insurance plans cover many, but this is a dwindling source of care. Over the last decade, employer-supported care declined by 8.7%, and the decline was over 9% for families under 200% of poverty. So the lowest income working people are losing coverage from employers fastest. Small group and individual coverage is expensive and often unobtainable. There's a host of problems in the insurance market, pre-existing condition problems, higher cost if you're a female, rescissions, lifetime limits, high deductibles, holes in coverages. There's a lot of difficulty, and what it amounts to is that everybody is under threat of losing your coverage and never getting it back. There's no control, there's very little choice, there's no peace of mind, which is why we have a health care reform bill. The Affordable Care Act was passed last year. It's actually, the full name is the Patient Protection and Affordable Care Act. It's abbreviated as ACA. March 23, 2010, it was signed into law. It will cover 32 million, about half of that with a Medicaid expansion. There are 52 million currently uninsured in the country, so it doesn't go the whole way, but it goes a substantial part of the way down the field to covering everyone. It addresses the cost of health care, not just the cost of health insurance, through things like prevention, care coordination, electronic records, and promotion of best practices. It does have the potential, the tools and pots of money are there to ensure affordable, comprehensive, quality coverage to most people, which would bring with it then choice and peace of mind and control for consumers and competition more so among providers, among health insurance companies. But that potential can only be realized if the states implement and make the right choices in implementing the law. A lot depends on what the states do. Now I'll turn it over to Kathy Chan, who will present on the ACA's public insurance provisions and how they might affect Illinois children and families.
Thank you, Don, and thank you to the Schreiber Center for inviting us to be part of this webinar. The Illinois Maternal and Child Health Coalition is a statewide organization that's dedicated to improving the health and well-being of women, children, and their families through policy change, advocacy, and community empowerment. We provide leadership to several projects which are listed on this slide. INCHC is very excited about the Affordable Care Act, as it will be especially beneficial to Illinois children and families providing them with new avenues for affordable health care coverage. In addition to the information being presented today, I encourage you to visit our website at www.ilmaternal.org for additional fact sheets on how the Affordable Care Act will benefit these populations in Illinois, and to learn more about the work of IMCHC. So today, the following topics are going to be covered in this part of the webinar. I'm going to talk about Medicaid, the Children's Health Insurance Program, or CHIP, maintenance of effort or stability provisions, the Eligibility Verification and Enrollment System, also referred to as EVE, and then finally wrap up with some legislative and administrative policies that you should consider and be aware of as we move forward. So first, Medicaid. One of the most significant expansions provided for in the Affordable Care Act is the expansion of Medicaid to all individuals under the age of 65 who have incomes below 133% of the federal poverty level, effective January 1st of 2014. Currently, Medicaid coverage in Illinois is only available to persons who meet income requirements and fit a certain category, such as being a pregnant woman, a parent, a child, or someone who is aged, blind, or disabled. And those in the aged, blind, and disabled category also have limits on how many assets they can own. For those of you unfamiliar with federal poverty level amounts, this chart should give you a sense of how much an annual income 133% is equivalent to. There will be no asset test for those newly eligible for Medicaid, but a new way of calculating income, referred to as the Modified Adjusted Gross Income, or MAGI, will apply to the newly and previously eligible. MAGI will take into account the household's gross income along with some standard income disregards. The Medicaid expansion starts January 1st of 2014, as mentioned earlier, although states have the option to adopt this expansion earlier. However, given Illinois' budget challenges, it is unlikely that we will do so. So who are the newly eligible? The Illinois Department of Healthcare and Family Services, the agency that administers Medicaid, All Kids, and other public health insurance programs, estimates that between 500 and 800,000 adults will be eligible for the Medicaid expansion. This will include tens of thousands of parents without children in the household, single men and women, and the majority of children who age out of All Kids when they turn 19 years of age. This is a population uninsured at higher rates than most other groups, who are expected to be in poor to fair health, have chronic physical and or mental health conditions, and who will not have received regular care or who have had access to maintenance prescription drugs. Current immigration rules for Medicaid will still apply to this expanded population, meaning that only U.S. citizens, legal permanent residents with at least 5 years of residency, and refugees and asylees will be eligible for coverage. Legal permanent residents with less than 5 years of residency and undocumented immigrants will not be eligible for coverage under the expansion. Given that this newly eligible population will also have numerous health care needs, what kind of benefits package will the Medicaid expansion include? Well, states will be required to offer a benchmark benefits package to those in the Medicaid expansion. Note that those who were previously eligible for Medicaid prior to the expansion will still receive the traditional Medicaid coverage package. Presently, the scope of the benchmark package is still unknown, but we know that at least essential health benefits must be included, such as ambulatory, emergency, and hospital care, maternity and newborn care, prescription drugs, family planning, mental and behavioral health, including treatment for substance abuse disorders, and lab services. States will have some flexibility in crafting their benchmark packages, and we should encourage our officials to provide the most generous packages possible. For example, Illinois' Medicaid program for adults does not cover preventive oral health care. This is most certainly a service that contributes to overall physical health and should be included. We should also review the newly eligible population and consider other services that may help them get and stay healthy. A question that may come to your mind is, how will we pay for all of these newly eligible people to be covered? Well, the great news is that Illinois, along with other states, will receive 100% in federal match to cover those who are newly eligible for Medicaid in 2014. The normal Medicaid match rate is 50%, which means that for every dollar Illinois contributes to Medicaid, we get $1 back from the federal government. So the expansion will be a fantastic deal for Illinois. The 100% federal match continues through 2016. In 2017 through 2019, the rate will slowly decrease until 2020, when the rate will remain permanently at 90%. So as you can see, even though Illinois will have to contribute some towards this coverage, the Medicaid expansion will still help draw down significant federal dollars to Illinois. And to strengthen the primary care provider network, in 2013 and 2014, the Affordable Care Act will provide states with 100% federal funding to increase their Medicaid reimbursement rates for specific primary care services up to Medicare levels. This will mean a significant bump up for providers in Illinois. But it's important to note that the 100% federally funded increase will only be for 2 years, and Illinois advocates will need to work with our legislature and administration to continue these rates beyond 2014 to ensure that we have a robust primary care network. This next slide is about the Children's Health Insurance Program, or CHIP, which provides a portion of the funding for our All Kids program here in Illinois. CHIP must be federally reauthorized every 4 years and was last reauthorized by Congress in 2009. The Affordable Care Act reauthorized CHIP, pushing back the next time Congress must take action to 2019. The ACA also continues CHIP with full federal funding through fiscal year 2015 and increases the federal match for this program. So from 2015 through 2019, Illinois will receive an increase in our federal match from 65% up to 88%, which again is a great deal for Illinois. I hope that most of you already know about Illinois' All Kids program, which provides affordable health insurance coverage to children here in the state. When the program was first expanded and Kid Care was renamed All Kids, the program allowed children who needed insurance from all income levels to be eligible for coverage, with those in higher incomes paying premiums and copays. But starting tomorrow, July 1st, an income cap will be placed on All Kids. The cap is set at 300% of the federal poverty level, or around $67,000 a year for a family of 4. Families with income above 300% who have successfully applied for All Kids and have been approved for coverage prior to July 1st will receive up to 12 months of coverage until July 1st of 2012, when no families above 300% will be able to have All Kids coverage. This is a result of Medicaid reform legislation that was passed by the General Assembly and signed by the Governor in January of 2011. Please visit our website and visit our policy brief section for additional information about the Medicaid reform legislation. Once the competitive health insurance marketplace or exchange is up and running in Illinois in 2014, we'll want to keep a close eye on the coverage available to children and whether these options are affordable for families and provide the comprehensive coverage that they need. These are all factors that child health advocates will take into consideration in deciding the future of CHIP beyond 2019. And for us here in Illinois, coverage of undocumented children through the All Kids program is particularly important. So we will be working to help preserve this and other parts of our program. The maintenance of effort requirement is also referred to as the stability provisions in the Affordable Care Act. These provisions prevent states from scaling back eligibility or imposing additional barriers for Medicaid and CHIP at the initial application process or at renewal. This was effective when the Affordable Care Act was signed into law on March 23rd of 2010. So states' Medicaid and CHIP programs cannot be reduced or changed in a way that makes it more difficult for children and families to enroll as of that date. Preserving eligibility is pretty straightforward, but what's meant by the procedural barriers? Well, this means that states cannot impose stricter requirements on applicants or enrollees, such as adding face-to-face interviews or requiring additional paperwork to verify income or putting into place asset tests if these things were not in place on March 23rd of 2010. Without these protections, many states would have moved forward with putting into place these and other barriers to prevent eligible families from getting coverage, so as to keep their Medicaid spending lower. Here in Illinois, the stability provisions have helped preserve simplifications to All Kids in Medicaid enrollment and re-enrollment processes. The same legislation that reduces All Kids eligibility to 300% also called for increasing the burden on families to provide additional income documentation and proof of residency. The federal government recently provided Illinois with verbal confirmation that enacting these provisions would violate the stability provisions. Therefore, HFS will not be implementing these specific changes on July 1st. States that are in violation of these stability provisions will put themselves at risk of losing all federal Medicaid and CHIP funding. A number of conservative governors and members of Congress have been calling for the repeal of the maintenance of effort requirements or these stability provisions. You can help us protect and preserve Illinois programs by responding to calls of action to Congress to reject these proposals. Without them, Illinois and other states would be preventing thousands of women and children from getting basic health care services to help them get and stay healthy. The Eligibility Verification and Enrollment System, or EVE, is an initiative being led by the Illinois Department of Healthcare and Family Services that will help streamline the eligibility determination system for both public and private health insurance programs, as well as for premium subsidies and enroll people into these programs. EVE will be part of the Illinois Competitive Health Insurance Marketplace, which is also known as the Exchange, which you'll hear more about from our next presenter. Requirements outlined in the Affordable Care Act requires Illinois' EVE system to be crafted in a way that is efficient, economical, and effective, that provides accurate and timely determinations and also communicates this information with consumers and providers. It should offer useful data and reports to be used in program evaluation and quality improvement. It seamlessly integrates Medicaid, CHIP, and health insurance exchange processes, including determining subsidies in private insurance. Uses a single application for both public and private insurance, and that's accessible online, in person, by phone, and on paper. Presently, HFS is working with program consultants to gather information about what systems will work best for Illinois and what changes need to be made to present technology and information systems to achieve the goals stated earlier. IMCHC and the Shriver Center submitted comments gathered from Illinois All Kids application agents and other entities that have experience working with the All Kids online application to help inform this process. Your feedback about systems issues will be critical in shaping EVE, and we encourage you to provide input towards this issue. Please feel free to get in touch with myself or Andrea Kovach at the Shriver Center to find out more about EVE or to submit your comments. Our contact information will be posted on the resources page. In review, there are a few actionable items that you should keep in mind. Attacks on Medicaid are taking place at the federal level right now. We need to continue to remind our legislators the important role that Medicaid plays in the health of women, children, and families in Illinois. If you're not already subscribed to IMCHC's e-advocacy list, please visit our website to do so and stay up to date on legislative issues. You'll be able to send an email to your legislators with the click of your mouse and have your voice heard. In addition to federal attempts to cut Medicaid, it's also important to let legislators know that the maintenance of effort or stability provisions that help Illinois continue covering kids and parents on Medicaid remain in place. We're also interested in hearing your clients' stories, so feel free to get in touch about these stories as well. State legislators also need to hear about the important role that Medicaid plays in keeping women and children healthy. Consider writing a letter to them, letting them know how Medicaid has helped your clients or patients, and ask them to continue their support of Medicaid. It's not often that they hear about how well programs work, so this would certainly be refreshing information to them. And given that hundreds of thousands of individuals will be accessing Medicaid and subsidies for private insurance and also moving between public and private coverage, it's critical that Illinois builds an EVE system and ensures seamlessness and conducts electronic verifications when possible to minimize the need for a paper trail and ensure continuous coverage for enrollees. Please be sure to contact myself or Andrea with any questions or to provide comment that we can compile and pass along to HFS for consideration. And finally, given that Medicaid enrollment will take place through the new competitive health insurance marketplace, also known as the Exchange, we will need to make sure that this system is built in a way that's most beneficial to children and families. And you'll learn more about how you can make sure this happens from our next speaker, Brian Imus. Again, thanks to the Shriver Center for the invitation to participate, and thanks to all of you for listening. Now I'm going to turn it over to Brian, who is going to talk about how the Affordable Care Act impacts private insurance coverage.
Great. Thank you, Kathy. Again, my name is Brian Imus. I'm the State Director with the Illinois Public Interest Research Group. I'm thrilled today to be able to join John Bowman and Kathy Chan to talk about the benefits of the Affordable Care Act and what it can mean for Illinois families and children. Illinois PIRG is a statewide research and advocacy organization that works on a whole host of issues focused around protecting consumers. And as a consumer group, what we care about when it comes to health insurance reform is reforming private insurance to lower costs, increase coverage, and improve quality of coverage for consumers. What I want to cover over the next 10 or 15 minutes, I want to talk a little bit about what an exchange is and why it's important, the nuts and bolts of what's involved and how it will benefit families purchasing in the private insurance market. The important policy decisions, because how the exchange is designed, governed, and operated will have a big impact on whether we'll see increase in quality of coverage and lower costs. And then finally, just conclude with an update on where we're at in Illinois and what we should all be doing to make sure policymakers design an exchange that works for Illinois families. So this slide could really be called Why Illinois Needs a Competitive Insurance Marketplace, which is really what an exchange is. In Illinois, insurers don't compete for our business. They instead offer take-it-or-leave-it deals. Important information about coverage is buried in the fine print. There's no real way to shop around. Add to that, costs for coverage have been rising dramatically. 77% of policyholders saw a premium increase last year with an average rate hike around 20%. In Illinois, health care costs for a decade have been surging such that they are dramatically outpacing the growth of the median incomes of Illinois families. And small businesses are particularly hard hit. They pay on average 18% more for insurance than their larger competitors and have seen repeated double-digit premium increases. To give you a sense of how bad it is in Illinois in particular, the U.S. Justice Department has defined the health insurance market in Illinois as highly concentrated. That means an insurer like Blue Cross can raise premiums and reduce the variety of plans or quality of services offered to consumers with little consequence because there isn't true competition. These cost increases are unsustainable for Illinois families. Clearly, there is a need for change in the private insurance marketplace, particularly in Illinois. For these reasons, it's no wonder that the Affordable Care Act has made meaningful and dramatic changes to protect those of us receiving coverage in the private insurance market. A couple of examples afforded consumers under the new law that I want to cover quickly. One, it prevents limiting coverage based on pre-existing conditions. For children, a ban on limiting coverage is already in effect, and the same will be true in 2014 for adults. Keeping young adults covered. Children under 26 are now eligible to stay on their parents' family policy or be added to it. No copays for preventative care, another benefit consumers are already experiencing because of the new law. The law also prohibits insurers from rescinding or taking away your coverage based on an unintentional mistake on an application. There's also federal funding to states to increase transparency on insurance rates. So the funding will allow states to review and prevent unreasonable rate hikes. Illinois should take advantage of this opportunity to improve oversight and require more transparency of insurance companies' requests to raise rates. There will need to be state legislation to do so. The Affordable Care Act also requires benchmarks called medical loss ratios for how much money insurance companies have to spend on care versus administrative costs. These new medical loss ratios and requirements, this will limit spending on overhead and salaries and bonuses paid to insurance companies and executives. So while these are baseline consumer protections federally under the new law, the requirement that Illinois develop an exchange to create a more competitive marketplace is where we in Illinois can go far and above these protections and really make an impact in improving coverage and lowering costs. So what is an exchange? Here's a simple definition. A health insurance exchange will allow individuals and small businesses to pool their bargaining power, creating economies of scale that will push insurers to improve coverage, consumer choice, and affordability. The ACA requires every state to create an exchange by 2014, and it is one of the most effective ways that the new federal law will be able to deliver on its promise of lowering costs, and the way millions of people will receive coverage once it's implemented. It's estimated over 1.2 million people will get their insurance cover. 1.2 million people will get their insurance coverage through these new competitive marketplaces in Illinois. So who can participate in the new marketplace created by the exchanges? Who's eligible? First, this is for those that don't have employer-sponsored care. So if you're an individual looking to buy, or if you are a small business owner and want to offer coverage to your employees, the exchange is the way you'll be able to purchase insurance. Legal residents can go on the exchange and are eligible for financial help provided by the law. I'll go into more detail in a moment on the financial help that's provided. undocumented residents are not eligible to take advantage of the exchange. So an exchange essentially creates an organized insurance marketplace, one where there is a single place or portal where a consumer can go to shop for health insurance. And since there are lots of products competing for consumers' business, it's more accurate to call an exchange a competitive health insurance marketplace. Done right, this new competitive marketplace will have information for consumers that make it easy to shop. It's a place online where there will be a clear array of health coverage options with helpful quality and customer service rankings and useful tools that allow someone shopping for insurance for their family the ability to easily compare prices and estimate potential out-of-pocket costs. The marketplace works because insurance companies will be competing for business for those that are using the exchange. And since it's a large pool of people purchasing through the exchange, it can spread risk and help lower costs. But this new competitive marketplace should be much more than just an Expedia for healthcare. In giving consumers better choices and offering the help they need in navigating the insurance market, it can act like the human resources department of a large employer, giving them the tools they need to pick the right program, educate them about their options, let them know if they are eligible for Medicaid or other public programs, and direct them to take advantage of those options. Of course, it's all in how it's designed by lawmakers here in Illinois. There are several clear and direct ways the exchange can benefit Illinoisans. However, it's worth noting that there are policy decisions to be made when creating this new marketplace to ensure families in Illinois truly see the most of these benefits. So first, the competitive marketplace created can help address costs by negotiating for a better deal. Just as any big business negotiates with insurers using the bargaining power of their employees to push for lower premiums, the exchange can negotiate for better choices and lower costs on behalf of consumers. But that means it must have the authority to exclude plans that fail to deliver robust consumer protections, quality care, and reasonable costs, particularly if the plan has a history of unreasonable rate increases. So the competitive marketplace in Illinois set up must have the power to say no. Also, because the bigger the exchange, the greater its negotiating power, the state should work to enroll as many eligible consumers as possible, creating programs to educate and engage those most in need. There's also an opportunity for improved transparency. Insurers in this insurance marketplace should have to use easy-to-understand language to describe their products. That'd be a big improvement today where sometimes understanding terms and jargon are a barrier for people looking for insurance. And insurers should be required to share information about plan costs and quality in a standardized way so that consumers can truly understand what they're getting. It's about being able to shop and compare prices just like you would if you were to shop for any other service or product. A huge benefit can be assistance so everyone can benefit from these new marketplaces. So most will shop in this competitive marketplace through a web portal. It must be well designed, ensuring that the language used is straightforward and addressing the diverse language needs of enrollees. There must also be assistance to those without high-speed internet to find coverage, providing a toll-free hotline and face-to-face assistance. So here there can be a big role for social service agencies to help those in need navigate the new competitive marketplace created by the exchange. It can help ensure stability and coverage. Once you're in the system, it should be designed so that you don't get kicked out or fall through the cracks because of changes in income or other eligibility changes. And if consumers have to change coverage, say from the exchange to Medicaid or from Medicaid to purchasing private insurance through the exchange, it should be seamless and easy so there are no gaps in coverage. And then finally, it's worth noting that the Affordable Care Act provides financial help each month to pay for out-of-pocket expenses. Those benefits are a sliding scale and are available to anyone under 400% of the poverty level. So There are many policy considerations for state lawmakers to consider and get right to ensure we truly end up with a competitive marketplace for those purchasing in the individual and small group market. I'm going to quickly touch on two that I think are most important. First, the exchange will be only one piece of the state's larger healthcare landscape, which will continue to include public programs like Medicaid and the Children's Health Insurance Program. Coordinating these various programs will help those most in need to prevent gaps in service and has the potential to save the state money through increased efficiency. Second, the program is meant to benefit individuals purchasing in the private market. It's not about helping insurance companies find more customers. So for that reason, the competitive marketplace should have a governing board that represent consumers and small business owners. The board should be free of influence from the insurance industry, brokers, and providers. And of course, everything the exchange does should be done transparently and with lots of public participation. For more on these and other policy considerations, I'd encourage you to take a look at the resource page that's provided through this webinar for more details and what's involved to make sure that lawmakers get it right. So as mentioned, the ACA requires states to set up an exchange for their residents by 2014. Illinois policymakers are already taking steps to develop a health insurance exchange. Unfortunately, that development and implementation of the exchange is occurring in a really politicized setting. Insurers and other special interests are already trying to drown out the public voice. So, for example, the insurance industry introduced their own exchange-enabling legislation earlier this year. They were pushing policies that would actually weaken bargaining power. The insurance-backed bill didn't pass in its original form. Ultimately, what did pass just this past May was a bill that requires a legislative study committee. So hearings by this legislative study committee could take place this summer. They'll have until September 30th to make recommendations with the goal of passing an Illinois exchange law before the end of the year. You can be sure Illinois lawmakers will be hearing from insurance industry leaders, brokers, and other business interests and their lobbyists. The hearings this summer and the debate that follows is our opportunity. They need to hear from Illinois families and small businesses that will benefit from a well-designed, competitive health insurance marketplace. And even once the program is created, there will be work to implement. For example, making sure the operating board is setting up the program so everyone can participate, and there are mechanisms to reach the communities that should be participating in the program. So be looking for action alerts and ways to educate and engage people who are most going to benefit from an exchange. Again, this is a huge opportunity here in Illinois. Thank you again. Now turn it back to John Bowman.
And I'm going to touch on delivery models, and you may wonder, why should you care about delivery models? That has to do with whether you actually get health care after you have coverage. In other words, whether you can get in to see the doctor and whether you can get what the doctor prescribes. It's about access to care, quality of care, consumer control over care, and the chance for the great twofer of health policy, less cost and better care all at once. The upside is care is delivered smartly and efficiently, it could cure some of the access problems that plague the current system and could promote prevention and care coordination and better health outcomes. The downside, though, as we've learned in Illinois repeatedly with HMO efforts, and Medicaid at least, is that if care is delivered sloppily and only to save money, it could damage access, especially for people with chronic needs. Here are some of the healthcare delivery models. The fee-for-service models, the providers are paid a set fee for each service, so it rewards volume and intensity of services, but it lacks incentives to coordinate care or emphasize preventive care or even produce any particular health outcomes. This model is currently predominant in the Illinois Medicaid program for most enrollees and also in the private pay setting. Coordinated care models are you pay the providers up front a certain standard amount of money, and you also could pay them for performance, either more or less depending on outcomes, in order to coordinate and ensure the full spectrum of services a patient requires. The ACA includes many provisions that reward providers for using a coordinated care model and the ACA establishes a federal coordinated care health office within the Centers for Medicare and Medicaid Services to more effectively integrate benefits and improve coordination between the state and federal governments for individuals eligible for both Medicare and Medicaid. Types of coordinated care models, one of them is called an accountable care organization. That's an ACO. That's where you coordinate care in one place, integrating primary care specialists, hospitals, labs, etc. Providers accept joint responsibility for the quality of care and cost of care patients receive. The ACA allows new payment arrangements for Medicare and Medicaid for health systems that qualify as ACOs. No organizations have yet been designated ACOs, but proposed rules regarding ACO in the Medicare Shared Savings Program were released on March 31st, 2011. So that's a process that's underway right now. There's also a provision in the ACA for a large Medicaid demonstration for pediatric ACOs. It's not known yet really whether Illinois is going to apply for that. Another model is patient-centered medical home, which is a primary care health setting facilitating partnerships among patients and providers. The ACA includes grants to support medical home models and policies to enhance payment for patient-centered primary care. In Illinois, as of June 30th, 2010, just under 1.8 million enrollees were enrolled with a primary care provider in the Illinois Health Connect primary care case management system. It's not clear yet, though, whether the Illinois Health Connect model will qualify. As it's currently constructed, it does not satisfy Illinois' own Medicaid reform law for full care coordination. So that's, again, another process that's in flux right now. And then finally, there's consumer-operated and oriented plan, or co-op. Nonprofit member health insurance, which offers qualified health plans based on an integrated consumer-focused model. In a co-op, the same people who own the company are insured by the company. Cooperatives can be formed at a national, state, or local level and can include doctors, hospitals, and businesses as member owners. This model is promising for certain populations, such as undocumented immigrants, who can't access Medicaid or buy insurance on the exchange. The ACA actually appropriated $6 billion to facilitate the creation of co-ops, and it would probably be very useful to add that to the Illinois marketplace. As you heard just a moment ago, it's a very non-competitive marketplace right now. So features of helpful care coordination. So the way you can sort of judge whether a care coordination proposal is going to be a helpful one or a problematic one. Well, the helpful ones are a patient-centered medical home that coordinates recommended care and incentivizes prevention and early detection. The providers are financially incentivized for good outcomes, which is contrast with the fee-for-service model, which just rewards volume instead of value. And the providers will be rewarded for good outcomes and possibly financially penalized for poor outcomes of their patients. There's plenty of use of electronic medical records among the providers. There's federal oversight of the new delivery and payment models. And it allows a good, helpful system will allow a chronic care specialist to be a medical home for somebody who suffers from a chronic condition, rather than having it be a generalist or an internist. Features of problematic care coordination, the classic HMO financial incentive to deny care. Problems exist in building the network of providers to participate in it. Chronic care patients are often denied access to specialists to be their primary care doctor. There's problems with access to newer expensive therapies, problems with access to chosen providers, with the insurance company getting in between you and the care you want to get. And there's problems with record keeping and accountability, which we've seen in Illinois in the past. So how are these healthcare delivery models currently playing out in Illinois? In 2010, HFS began planning an integrated care coordination pilot program. Integrated care program, it's called, for 40,000 seniors and persons with disabilities in the Illinois Medicaid system who live in suburban Cook, DuPage, Kane, Kankakee, Lake, and Will counties. HFS contracted to pay a pay-for-performance payment model with Aetna and Centene Illini Care. So there's two insurance companies administering this. As of June 13th, 31,298 enrollees had been included in the program. It moves away from the current fee-for-service delivery system, and so it's underway right now. They're having some difficulties attracting all the providers and the hospitals in the region to participate in it, but it's underway right now, and they're working on getting it up and running and on constantly improving it. The integrated care pilot is just the first step for HFS in its move to change healthcare delivery models for Medicaid enrollees. The next phase is found in the Medicaid reform legislation that was drafted by the special committees on Medicaid reform in both the Senate and the House in late 2010 and then passed and signed by the governor early in 2011. One of the provisions of this law states that at least 50% of recipients eligible for comprehensive medical benefits in all medical assistance programs or other health benefit programs shall be enrolled in a care coordination program by no later than January 1st, 2015. Care coordination is defined in the law as delivery systems where recipients will receive their care from providers who participate under contract in integrated delivery systems that are responsible for providing or arranging the majority of care, including primary care physician services, referrals from primary care physicians, diagnostic and treatment services, behavioral health services, inpatient and outpatient hospital services, dental services, rehabilitation, and long-term care services. And payment for coordinated care in these programs will be based on pay for performance related to healthcare outcomes, so getting away from fee-for-service. There will be capitated payments and a monthly fixed amount per person. Parents, children, seniors, and people with disabilities will all be enrolled to try to meet this 50% goal. And Illinois Health Connect, the state's current primary care case management system, under its current organization, does not qualify. It is not a deep enough network. The exact definition of care coordination is still being discussed by HFS, and toward that end, they are hosting meetings this summer. The first was on June 16th. On the topic of what care coordination should look like for the Medicaid population. The next meeting will be July 19th. Implementation of care coordination must not only comply with the Illinois Medicaid reform law, but also conform to the federal ACA provisions. On this next slide, I'm just giving you a heads up to things that are on the resource page. Also happening right now is a hospital payment reform to align with the ACA, and an upgrade of information technology, a lot of medical records, and there's a special website for that. There's also, starting on the south side of Chicago, something called the Medical Home Network, which is an example of a care coordination network that's an experiment being tried on the south side. It's a new safety net accountable care organization funded by a foundation that is set to launch this summer on Chicago's south and southwest side. Will target women and children enrolled in Medicaid at greater risk for readmissions into hospitals. It will link hospitals and medical clinics on Chicago's south and southwest side through an internet portal. If a Medicaid patient from a participating clinic comes to an emergency room or is admitted or discharged from a hospital, the clinic where the client gets primary care services will receive an alert within 24 hours with basic information about the reason for the patient visit, the diagnosis, the medications prescribed, and a short summary of the care plan. Clinics will then contact the patients and offer follow-up care within a week. Hospitals and clinics, ER doctors will all have a window of recent medical activity, 90 days worth of Medicaid data about which prescriptions patients have filled, which tests have been ordered, and so forth. Participating hospitals are expected to increase access to specialty care consultations by opening up access to a broader group of clinics and physician practices. The hospital partners include Stroger, Provident, Oak Forest, Rush, Mount Sinai, Holy Cross, St. Anthony, and La Rabida. Clinic partners include Access Community Health Network, Alivio, Lawndale Christian, Chicago Family Health Center, Centro de Salud Esperanza, Friend Family Health Center, and outpatient clinics run by the participating hospitals. So keep your eye on the Medical Home Network. So by law, HFS has to report to the General Assembly starting next year on the implementation of care coordination so that they will keep at it. Hospital payment reform legislation is also expected next spring. In 2013, plans have to begin enrolling newly eligible Medicaid clients under the ACA. They have to get enrolled in the fall of 2013 so that when they turn the switch on January of 2014, they're enrolled and they're in care coordination models. So that whole big new population, hundreds of thousands of new Medicaid, is part of the 50% challenge faced by the department to get everyone in care coordination. In 2014 and beyond, the landscape will, just to summarize, it'll be most Illinoisans will be required to purchase coverage under the ACA's mandate. The exchange will be operational, expected to be covering 1.2 to 1.3 million people. 700,000 Illinoisans or so will be eligible to enroll in Medicaid, and that enrollment will take place through the exchange. At least half of enrollees will be in care coordination by 2015. There will be many care coordination models out there, accountable care organizations, medical home networks, and others, co-ops. And then there's a lot of money in the ACA for significant expansion of community-based clinics, both for building out current ones and for building new ones. Now, I wanted at last finally here to touch on some things that are in the news all the time that you're going to hear at the barbecue this weekend about the health care law, and I wanted to just give you some facts so you can counter some of the myths you'll hear. As far as the lawsuits go, I think the lawsuits almost entirely have to do with the health insurance mandate. The lower courts, lower federal courts have been split. Some have upheld it, some have struck it down as unconstitutional. They are now pending in the Court of Appeals, and just 2 days ago, the Sixth Circuit Court of Appeals in Cincinnati ruled that the law is constitutional. It upheld the mandate as constitutional. One of the judges on that panel was a George W. Bush appointee, so it doesn't necessarily get decided based on the political persuasion of the judge. I would say that the Supreme Court is going to be deciding this. That's almost a foregone conclusion, probably sometime in 2012. I would say that the mandate is about a 50-50 proposition for how the Supreme Court will handle it, but the legitimacy of the entire health care law is not, I think, and is not. There's a theoretical threat to it in the Supreme Court case, but it's a much lower order of probability, and it's unlikely that the law will be struck down by the Supreme Court, I would say. As to repeal, some people say, well, this law is just going to get repealed. In fact, the House already passed the repeal law, but the Senate will not call that law, and even if the Senate passed it, the President would veto it. And so there's no chance that the law will be repealed by Congress, except, of course, depending on the outcome of the 2012 election. Elections matter in this case. That'll be one of the issues. There's also rumors about defunding health care reform. Will Congress defund it? There are actually deep threats right now to the Medicaid program in the Republican budget proposal in the House by Representative Ryan. Anything that smacks of a block grant or of reduced matching funds to states would deeply threaten Medicaid and therefore threaten the health reform proposals that you heard Kathy talk about earlier. Other parts of the ACA the funding could be threatened in the annual appropriations process. So yes, there will be battles about funding You need to pay attention and help when there's an alert. Finally, public opinion. Public opinion has trended up. It has sort of flattened out a bit, but the majority now say don't repeal it. It's a thin majority, but it's a majority. And as implementation proceeds and the benefits continue to flow from this act, we think that the public opinion will grow. It'll be harder and harder to repeal this law. So that's it. We'll turn to some questions.
Thank you. That concludes our presentation. We have time for just a few questions. If we don't get to your question during this webinar, we will respond to you directly or on the resource page. Our first question went to Kathy Chan.
So the question that we received is there a real chance that all kids may start restricting access to care for kids who are undocumented immigrants or who are here for less than 5 years? I would say that anything's on the table at this point, and I think it's important for those of us that certainly work with children, children's health, and children who are undocumented to continue talking to legislators about all of the great benefits that All Kids does bring to all kids. Right now, just to reiterate, the changes to the All Kids program that are happening on July 1st have to do with eligibility for those families above 300% of the poverty level. So undocumented children are not affected unless they're in that population that are above 300%. But like I said, moving forward, anything's on the table. Usually in Springfield, the issue of the coverage of undocumented kids comes up every year. I think because of advocacy efforts from a lot of you who are out there and a lot of us who are in Springfield on a regular basis help tamp down some of those threats. But it's something that we'll just need to keep our eye on and continue to champion.
I had a quick correction to make. This is John. I said that 38,000 plus were enrolled in the integrated care pilot. That's the targeted enrollment. Actual enrollment right now is smaller. It's just a few thousand right now. They're in the opening stages of enrolling people.
Our next question will be answered by Brian Imus.
So the question is, who or what agency is creating the exchange in Illinois? It's up to Illinois lawmakers to pass a law that determines how the exchange is governed. Here in Illinois already, the Department of Insurance held stakeholder meetings earlier this year and has recommended the creation of a quasi-governmental agency, and that's actually what Illinois lawmakers are debating right now, how to set up that quasi-governmental agency. However, there are really big questions on who gets appointed to the board to manage the exchange, how they're able to make decisions, and all of that will be decided through the legislative process. And so, again, it's very important that lawmakers hear from Illinois families who are going to most benefit from how effective and successful the exchange program is.
Here's the last one we'll be able to deal with on the call. If the mandate is deemed unconstitutional, will it harm foundational funding mechanism and halt implementation? No, is the short answer. The reason that the mandate is in the Act is as a mechanism to get healthy people to buy insurance, so that the overall cost of it, so it spreads the risk out, and the overall cost of insurance is lower because not everybody buying insurance uses it a lot. And so if the mandate is struck down, there are other ways to get people to sign up for insurance. There could be carrots instead of the stick, for example, and they're already making plans to do that. There's nothing about the mandate that has to do with the funding of the program. What it has to do with is whether the insurance available through the exchange is as affordable as it can possibly be because healthy people are participating in the pool.
So we are going to wrap it up here to be mindful of your time. All presentations and additional resources will be posted on the webinar's resource page, which is shown on the screen. You will also receive an email with the link to the resource page. Stay tuned for an email inviting you to register for the next webinar in this Illinois Health Matters series of webinars on the implementation of the Affordable Care Act. Thank you again for attending today's webinar. Please complete a short survey that will appear on your screen when you leave the webinar. If you have any questions, please contact me at andreakovach@povertylaw.org. Thank you.